yeah, it looks great.
So far, so good. Nothing like a good start, right?
Of course.
We'll just wait here a few more minutes to see if we can gather some more subscribers. All right, everybody, we've probably got just about the people we're going to have. There may be a few more coming on in the next few minutes, but let's go ahead and get started. Let me start with whether any of you have any questions or comments that you'd like to make at this point.
Keith, can I add on to that? And if anybody's having any technical issues viewing the YouTube videos that I've posted to the core site, or have any suggestions or comments on that, please feel free to enter chat and just make those notes there, and I'd be more than happy to make those changes.
Thanks, Katie. While you folks are thinking about that a little bit, let me just make one announcement. Tomorrow is our doubleheader day again. Wednesdays are 11 and 1 o'clock. And Elizabeth Putnam will be with us for both those sessions tomorrow. It's really fantastic to have Liz available to do this, because she's a real expert in the area of pharmacogenetics, which is the topic for both of those lectures. And as I'm sure many people know, pharmacogenetics is a really hot topic in the pharmaceutical sciences, and certainly one of the more important ones that we can tackle in a sort of a current events based sense. So Liz has done this for a number of years now, and typically the lectures have been highly rewarding for students. So I really encourage everyone, if at all possible, to join us at both times, 11 and 1 tomorrow, for pharmacogenetics. And then Thursday at 1, I'll be back with you to do more pharmacokinetics and related topics to that, as we continue to work on our introductory aspects of pharmacology. Does anybody think of anything they want to ask right now? Okay, if not, of course, feel free to ask anywhere along the way. For current event today, I brought in a recent issue of Smithsonian magazine, which might seem like an unlikely source of information, but it's kind of fascinating to me that Smithsonian is an example of a publication which does a lot of different things sort of eclectically, but they really do pop science very well. And each issue of the journal has typically one or more really fascinating pop science articles. This particular one, this is the June issue of Smithsonian. And there's an article here that has some reasonably local connections, as well as being important in terms of the current COVID pandemic that we're all suffering through. So let me just do a little bit of this article for you. It's called "Predicting the Pandemic," and subtitled "How a Medical Researcher Protected Millions of Americans from a New Contagion." And I'll just read the very first part of this. In April 1957, a new strain of a lethal respiratory virus emerged in East Asia, caught local health authorities by surprise, and eventually killed masses of people worldwide. So this is 1957 they're talking about now. Today, in the age of COVID-19, that scenario sounds frighteningly familiar, with one key difference. Maurice Hilleman, an American microbiologist then running influenza monitoring efforts at the Walter Reed Army Institute of Research, saw the problem coming and prepared the United States ahead of time. "This is the pandemic," he recalled, saying, "it's here." And just a little note on, and I may not be pronouncing this right, it's either Hilleman or Hillman, is a Montanan, was born in Miles City, if I remember right, and I believe went on to do his undergraduate work at MSU Bozeman, which would have been MSc at the time. Didn't become MSU until I think 64, 65, somewhere in that range. So this is kind of a really incredible story of science and clinical work, as well as basic research. And considering the magnitude of what happened in Hillman's lifetime, a little bit amazing that he's not better known than he is. I'll go on and reading just a little bit more of this. Hillman arranged for the U.S. military to ship samples of the pathogen believed to be a novel influenza virus from Hong Kong to his lab in Washington, D.C. For 5 days and nights, his team tested it against blood from thousands of Americans. They found that this strain, H2N2, was unlike any flu that humans were known to have encountered. When it reached the United States, no one would be immune to it. He quickly moved to alert the government, even predicting when the virus would hit U.S. shores, the first week of September, right when schools would reopen. In the years since the 1918 pandemic, health officials had lost sight of the deadly power of aggressive strains of influenza virus, and the U.S. Public Health Service ignored his warnings. That does sound a little bit familiar, doesn't it? I was declared crazy, Hillman told the pediatrician Paul Offit, who reports the conversation in his book, Vaccinated. Still having identified the new strain, Hillman sent samples of the virus to the 6 biggest pharmaceutical companies, directing them to produce a vaccine for this new flu, and they did, partly out of respect for Hillman himself. He had that sort of clout within the industry, said George Denner, a historian. And I won't continue reading here, but anyway, I think you get the idea here about the importance of this issue, the incredible. Just one other little note on Hillman. He went on eventually to work for Merck, and they developed something like 40 um, different vaccines. It was an incredible piece of production that they had. And so in the mid parts of our previous century here, you can imagine just how important this work was as we began to accumulate vaccines for a number of deadly organisms. So I thought people might kind of like the local connection as well as the currency of it in terms of our own pandemic right now. Um, so I don't know if anybody has any questions at this point, if you or comments on this. If you do, feel free to jump in right now. Okay, well, let's toggle through our introductory lecture here, and I just heard hip shot meow. That's not coming from the PowerPoint. It's coming from our house. See if I can find about where we were, and then we'll continue with this. And then after that, we're going to take a somewhat closer look at drug disposition. And you can see the subtopics listed here. Even at that, it'll still be a fairly quick look because pharmacokinetics is an essential tool that we must have in this course, but this is a pharmacodynamics course. So we spend most of our time on pharmacodynamics, but the two subdisciplines are, of course, linked with each other. And we can't really effectively talk about the meaningfulness of pharmacodynamics without laying at least a little bit of a foundation for pharmacokinetics. Well, if you recall, as we started off last week, we took a look at this theme slide from the conclusion of last spring's 444. And we've talked about a number of the bullet points here already. I have some different versions of this slide, and some of the other versions have some other bullet points added, and I might add one right now, and that is that metabolism is a prominent theme for us, and not only metabolism in the sense of taking a drug into the system and metabolizing it prior to its elimination, but also in the context of more generalized metabolism in the body. Of course, carbon oxidation is absolutely critical uh, for us to generate ATP and the energy that's responsible for all of our cellular processes. So knowing that that's such an incredibly important thing for biology in general, no wonder that many drug substances uh, directly or indirectly influence our metabolic status. And therefore, I'd like to add a bullet point theme in here for metabolism is being a very critical thing, and I think you'll see that play out as we visit various drug groups over the course of the year. Um, Another one that I don't think we've talked about yet, but I'd like to say just to touch about right now is this point that's on the slide here called that I call the ecosystem slide. The body is an ecosystem. Um, we we tend to target drugs towards specific things. So, for example, we might target the respiratory system because of some problems that an individual is having relative to having lost homeostasis in the respiratory system. Um, but of course, drugs are imperfect tools, and they have effects beyond what we are targeting, and that's of course part of the issue with adverse effects. But even beyond that, we may have unanticipated effects from an administration of a particular drug that are even on the beneficial side, but not directly obvious with respect to the reason that we're using the drug therapeutically in the first place. So I like to come out with the point that as we tweak a particular part um, of our body, um, it has domino-like ramifications throughout the system, larger and smaller, and we have to really keep that in mind, as well as keeping in mind, the major effects that we're looking at in the particular classification that we've given to that particular drug substance. Um, so um, anyway, as we go along throughout the year, the importance of these various bullet points here in these themes will probably somewhat subside for us as we become heavily occupied with the various intense data areas that we'll be looking at. But if we possibly can, take another look, step back, look at the big picture, try to fit what we're doing in sort of the small picture along the way into the larger scheme, I think it will help us immensely in the long run, not only in terms of these two courses, 443 and 444, um, but in terms of a lifetime of pharmacology as all of you apply that in various aspects of the pharmaceutical sciences. Um, as pharm tox evolves and the load of facts becomes greater and greater and greater, the density of the forest, if you will, becomes thicker and thicker and thicker, and it becomes a greater and greater challenge to keep track of sort of the big picture. But it's important to keep track of the big picture because um, that's sort of the underlying foundation for all the discrete facts that arise along the way. So we'll need to keep reminding each other to not only focus on the detailed, smaller picture, but the broader, larger picture. And this slide is just some thoughts in terms of important generalized themes that will be useful to us as we go along. So we'll keep coming back to this time and time again as we move throughout the semester. So I think most of the general principles listed in the next slide we've already talked about. Obviously, we were just talking about the fact that drugs have multiple effects, and there's not a drug that I know of that doesn't fit the idea that there are both beneficial and detrimental effects associated with that drug substance. Now, the balance of those may vary a lot from one drug to another. And so you may have, certain substances in which that balance is far on the side of beneficial, and even though detrimental things occur, they're not very prominent. And then other drugs where the detrimental side of it is pretty dramatic. So we'll try to do the best we can for talking about both of those aspects as we proceed, and trying to uh, keep in perspective the balance that exists, the risk benefit balance that exists amongst those various effects. Now, one thing that we may have talked about a little bit, but maybe not by specific description, is the third bullet point on this side, and that is that drug effects are so-called state dependent. This is a really fascinating area, and it's one when I was in graduate school a few decades back, this was an area of pharmacology that literally did not exist, or at least it didn't exist in many people's minds. I give you a quick little story here from my early graduate school days. There was a senior graduate student in our department um, getting ready to do his dissertation and finish up and head out into the big old world of research. And he had his committee formed, and he proposed uh, a study area which we would now include under this area of state dependency. And the committee refused the proposal. They said, no, you can't do your dissertation on this area because this is not an established area of pharmacology, and in fact, this area doesn't even exist. Well, that turned out to be wrong. He ended up doing his dissertation on something else since they wouldn't allow it, but uh, just to show you how the field has evolved since then. Uh, State dependency, or sometimes called setting, is so immensely important now in our overall view of drug effects. And basically what it's talking about, another way you could kind of do it, talk about it, and this might sort of take us back to this sort of ecosystem thing. If we think about pharmacology as sort of an ecological science, then state dependency is environment. It's that environment that the drug substance is used in, which is so critical beyond sort of our initial estimation of what the effects are going to be. And some aspects of environment have long been studied, but may not have been sort of conceptualized in the same sense. So, for example, the nutritional status of an individual is important in terms of what some other drug effect might produce, whether that individual's in good health or not, whether there are other disease states present. Um, it can even be to things like where the drug is administered, and by that I don't mean absorption applications to ourselves, but um, are you taking it at home? Is it in the hospital? Administered in a clinic somewhere? Is it a drug which has the possibility to be delivered in some quote unquote unusual setting, um, like a bar or someone else's home, or just think of any sort of environmental situation that you can imagine. And that's an example of something that can perturb a drug effect via state or set dependency. Um, so it's still a very live area of research. And since pharmacology got a really late start uh, on it, since it wasn't until late last century that it was even recognized as an important area of study, there's still a long way to go in terms of understanding how other factors beyond the ones that we typically think of are influential in terms of ultimate drug effect. But important it is indeed, and very much within our repertoire now to think about these things as we proceed. And I guarantee you, if a student was to uh, talk to a dissertation committee these days about doing a project in terms of set or state dependency, it would be viewed as right on the forefront of pharmacological inquiry. So I just tossed in some dose response curves here just to for the fun of it. We'll be seeing a lot more of these as we move into our pharmacodynamics segment in a couple lectures down the line. Um, so this is just a stylized dose response relationship here. And of course, the points to make are ones that you're already familiar with. But the typical approach to graphical representation of all important dose response is typically in a way in which the concentration or doses of drug in question are typically listed on the x-axis and typically from left to right, smaller to larger amounts. And then whatever response you're measuring listed on the y-axis, bottom to top. And there's various ways of representing exactly what you mean by response. That has to be carefully defined. So the next one, I just took the next one to make a real world dose response relationship. Looks a little bit different in the sense that what is being measured is such that the, the response actually falls off from left to right, and so that's a little bit different representation, but it's still dose or concentration on the x-axis, some type of response on the y-axis, and we just have to be careful as we look at individual dose response curves as to exactly how those doses and responses are being represented. And typically points are bracketed by some sort of statistical relationship that gives us an idea about the variability of the measurements at that particular amount. So statistical analysis is very important in analyzing these things. And I just thought I'd show you an example of a dose response relationship, which isn't as stylized as the previous one and is a real world that came from our own studies. Well, a century ago, things like dose response were recognized as important in pharmacology. And it was postulated that drugs would be interacting in the system with some sort of target biologically, which then was able to give us that variable biological response, which we're measuring on the response side of dose response. But as to what the targets were was completely unknown. And it is fascinating to note that in some of the early history of pharmacology, let's say around the turn of the previous century, so 100 to 125 years ago, somewhere in that range, some brilliant early pharmacologists like Sir Henry Dale from Britain were able to make speculations about the nature of drug targets, which then they called receptors. But again, it was theoretical, not practical, because we didn't really have the experimental tools available to us at the time to bring the targets into focus from a real world physical sense. But in 2020, now many, many different receptors or other drug targets are known, and quite a bit is known about their physical state. Uh, Although there's still a tremendous amount to learn there, and in your lifetimes, more and more and more will unfold along these lines as technological work continues to improve, and our ability to move from concept to reality, if we want to use that term, reality, gets greater and greater. So on this next slide is one of my favorite cartoon slides of a 7-transmembrane domain G protein coupled receptor. Um, and we'll certainly utilize this cartoon as well as similar sorts of approaches many times as we proceed over the next many months of pharmacology. All of you are familiar with the G protein coupled receptors already. And so this will, as we move to the pharmacodynamics section in a few days, it'll kind of be a review for you. But I put it up in this particular situation because in the pharmacology world, the 7-transmembrane domain G protein coupled receptors are one of the, if not the most highly represented forms of receptors that we currently know about. From a temporal standpoint, interesting to note, I think that in many ways, from not from a biological standpoint, but from a human study the biology standpoint, the G protein coupled receptors are relatively recent introductions to our area of understanding. And it wasn't until about the late 1970s that this superclass of huge number of receptors was recognized biologically, and then, of course, applied to the pharmacological world. Now, the G protein aspect of it had actually been known for some time, but in the early going, it was not recognized that the G proteins were actually coupled to the 7-transmembrane domain receptors in the membrane, and that they represented a team for signal transduction. So just tossing this out as one type of important receptor system. Here's another little cartoon that maybe puts it into a little bit better context, in that in this particular cartoon, the G protein is regulating the effector, and the effector can be something like adenylyl cyclase, which is responsible for the conversion of ATP to cyclic AMP, as you know. So sort of the real business end of these receptors as far as drug response is concerned is the effector, or effectors in the plural sense, because these are the mechanics that are actually producing perturbation within the cells that eventually generates what we recognize as an overt pharmacological effect. Something like relaxation of smooth muscle, or increased heart rate, or stimulation of the gastrointestinal tract. These are all well-known physiological parameters which are regulated by various effectors in the cell. And the effectors themselves, of course, are regulated by the target, in this particular case, another G protein coupled receptor, GTP, or G protein combination. So this is sort of the core of pharmacodynamics now. And again, we'll be saying more about that as we proceed later in the week. So a lot of our interest in 443, as I've mentioned before, comes with respect to the nervous system, both peripheral and central. And somebody like Katie, who's a scientist that studies the impact of individual neurons or small combinations of neurons is someone that will talk to you a lot about how effects are occurring at what I've sort of called the small picture or the microscopic picture here. Of course, there are bigger pictures than that too, anatomical combinations of large numbers of neurons or neurons interacting with effector cells in various organs, such as the vasculature or the heart. And so as we look at what's known about a mechanism of action for drug substances, we'll look both at small pictures like this, individual neurons or even subcomponents of those neurons, or the much larger picture, and try to put that all into context in terms of important actions. One of the complexities of all this is that as a nerve cell impinges synaptically upon another nerve cell or some non-nerve cell, such as, for example, a hormonal secreting cell, we'd like to think that maybe there could be physiologically one neurotransmitter that's emitted from the presynaptic side and one type of target receptor on the postsynaptic side. But life is not quite that simple. And so as pharmacologists moved into the realm of studying mechanism of action via known hormones, neurotransmitters, paracrine actions, and so on, for many decades, it was imagined oversimplistically that you could account for the actions that were occurring in those particular locales by a single neurotransmitter and by a single type of drug receptor or physiological receptor. This began to break down on the receptor side first, actually, as multiple target receptors were either postulated or recognized experimentally before it was recognized that a given presynaptic side might have multiple signaling molecules which are targeting those receptors. So anyway, we'll at times sort of act like major effects occur in a more simplistic sense, but we always have to be cognizant of the idea that pharmacology is more complex than simple minds like mine would like to make it be. And so as we learn more and more, of course, the level of these complexities increases dramatically. And that is not only fascinating in a biological, pharmacological sense, but challenging in a sense to learn it and keep track of all of it. So that's part of the evolution of the area. So I think that's the last slide in this sort of potpourri of the introductory thought processes. We've been thinking about where drugs come from, and now complexities like we've looked at here, and dose response and relationship with pharmacokinetics and developmental aspects of drug substances, and a number of other things as we've sort of introduced ourselves to some of the lingo and ideas of pharmacology. Now, to continue with that a little bit further, I would like us to begin our quick look at some drug disposition or pharmacokinetic aspects of drug action. And so let me switch over to that PowerPoint. So Katie, you might want to give me a little hand here. Should I hit this stop share and then start again? Okay.
Yeah, Keith, that probably would be the best bet.
Okay, let's try that. And I'll do share screen again and see if I can find where we are. This ought to do it. Try to share that. And
that looks great.
You know, some days I just luck out and other days I don't. There we go. Okay, so um, this area, which for most of you is an area that you're going to have in incredible neat study coming up in the pharmacokinetics course. Um, so here is, just a very brief review of some of the things which are important to us in the context of understanding pharmacodynamics of drug action. So sort of in the old days, this was called drug disposition. And now it's called either drug disposition or pharmacokinetics. And the idea of drug disposition is another one that people oftentimes associate with this area. And that is, I think I mentioned before, pharmacodynamics is the effects of drugs on the system. Pharmacokinetics is the effects of the system on the drugs themselves. Um, and I also want to remind you that since um, I am an amateur as far as pharmacokinetics is concerned, if I say something that violates the rules of the pharmacokinetics that you folks are learning elsewhere, let me know about it, and I'll apologize deeply and and note to you that you want to keep in mind what your pharmacokinetic experts are saying about this area, not me. So this slide, which I'm not going to, go through point by point, um, but I do want to say one important thing about, and that is on the left-hand side of the slide, and about midway down, you'll see that green rectangular box labeled drug concentration at site of action. That is, is pharmacodynamics right there. Um, that's why we need to think about pharmacokinetics a little bit, because these kinetic or dispositional parameters, which are altering the situation for the drug within the biological system, are all determinants for any given point in time what the concentration of drug is at some site or sites of action. And so, in the therapeutic sense, that's dose response. In the sort, you can take that clear down to the test tube level and look at that in a concentration-based sense. So it's concentration of drug that coming from dose that's administered, and ultimately leading then to changes in the level of drug action, whatever action we might be looking for. We might be looking for some impact that's occurring at the level of the pancreas, for example. So we're interested in drug concentration there, and that leads us down that pathway of concentration effect or dose response. So that summarizes in that little green box there why we need to think about pharmacokinetics. So pharmacokinetics in many ways involves those areas that we talked about before. And on the left side of this slide, you see absorption, or of an administered drug. You then see these various reservoirs in which the drug may be delivered to once the drug is inside the system. Most drugs have chemical characteristics such that if they're able to enter into the system well and get into cells or perturb cells from the surface of the cell, the chemical characteristics of the drug are such that the drug wants to stay in the system and basically not leave, which is, generally speaking, not a good time frame to have such a long time as that. So most drugs then have to be metabolized or chemically transformed for them to ultimately be eliminated or excreted from the system. And so you can see various uh, words relative to those particular ideas in this particular slide. Um, of these areas, metabolism is perhaps the most complex and highly studied of the various areas. And so you can have whole courses on drug metabolism itself. So our look at it is going to be pretty superficial, but we'll need to do a little bit anyway, again, to put ourselves into the context of how these things are changing pharmacodynamics. So expect to hear a little bit more about metabolism in the next few days than some of these other areas. Um, so, just to give an example, a drug like alcohol is almost completely metabolized before it's eliminated. So somewhere in the range of 95 to 100% of an administered dose of ethyl alcohol is metabolized, and then various metabolic products are excreted. And we'll talk about that, of course, when we talk about ethanol um, a little bit later in the course. Um, th- that would sort of be the more common example, really. If we take something like amphetamine as a counterexample to that, amphetamine is pretty much ready to be excreted once it's delivered to the system. So whereas almost all of alcohol is metabolized, um, only about 10% of amphetamine is typically metabolized prior to elimination of the original drug. So about 90% of amphetamine itself and related drug substances are eliminated without metabolism. So you can have both of those extremes, and most things, of course, fall in the middle. So our body, including the many compartments in which drugs may find themselves eventually, is composed of a series of membranes, which is once again a topic that you folks are readily familiar with. And making very, very, very broad generalization, uh, most drugs that can be absorbed into the system and then ultimately distributed in various sub regions of the system, typically are relatively small in size. So the larger the substance, often the harder it is for those drugs to cross biological membranes. So peptides and proteins, for example, are typically examples of substances which have a hard time passing through a biological membrane, unless, of course, there's a specific transporter for that particular substance. And those transporters do exist. And we'll devote a little bit of time to the dramatic area of transporter function here in a couple of days. And then I'm sure you'll hear a world about it from Katie, since she's a transporter person. Um, so size is an important physical characteristic. Um, solubility uh, is the particular drug substance, polar? Is it non-polar? Is it fat soluble, water soluble? Does it sit somewhere in between? Are the polarizations of that substance related to ionization? Um, and how does all of this relate to the drug substances themselves in a formulation sense, which sort of gets into the realm of pharmaceutics, and I won't really talk about that much at all. But again, for many of you, you'll have a world of wonder to realize in the pharmaceutics course and courses that you'll be taking. So for our particular purposes right now in pharmacology, the size of a drug and its solubility characteristics are amongst the most important things we can think about, because that's going to be major factors in terms of the ability have the drug substance interact with membranes, pass through it or not, or once inside the cell, passing back out through the membrane can be an important consideration. So in our ADME categorization, absorption of drugs into the system is the first place for us to look at. And I don't know if your pharmacokinetics folks talk about this or not, but I like to think about ADME as sort of the life history of a drug. Thinking about its birth, if you will, as it's administered and absorbed into the system, and then a lifetime of things that happen to it once it's in the system, and then its ultimate death, if you will, as it exits from the system. So amidst that life history, of course, are varying changes of concentration of drug in the system, much as in a biological organism, there are changes in the life history of that individual as they proceed from early development to the end of their lives. And in thinking about it this way, the complete elimination of a drug substance from the system would occur when you're down to 0% of drug in the system. But most drugs, not all, but most drugs obey first order kinetics. And if you think about first order kinetics from your experiences with biology and math, you know that we're talking essentially about what amount to hyperbolic functions in which we have a curvilinear relationship in which that curve is approaching an asymptote on the y side of the graphical relationship. And in terms of the calculus, that those limits are limits. You approach them slowly, but you don't ever get there, right? And so in a purely mathematical sense, you probably don't ever really get the drug totally out of the system. But from a pragmatic pharmacological sense, you eliminate so much of it that you're essentially effectively down to zero, even though you're not technically all the way there. That's kind of an interesting little mathematical point, I think, with respect to pharmacokinetics. So there's more for us to talk about, particularly with respect to metabolism as we proceed through this. So with a little layoff from this, with Liz being here tomorrow, although she'll talk about many of these important things herself, particularly metabolic things, we'll renew our look at this particular PowerPoint on Thursday at 1 o'clock. But tomorrow, 11 and 1 with Liz in the realm of genetics as far as pharmacology is concerned. So see you all tomorrow with Liz at 11 o'clock. Take care, everybody. Safe in the meantime, and good being with you again today. Take care.
Have a good day.
Anybody have a question?
Thanks, Keith.
Oh, you're welcome. Best
Thank
wishes,
you.
everybody.
Thank you.
If you're not already home, go home and give the dog or cat a pet. See ya. Well, we got through it today without messing up screen share.
No, I think it really worked well today, Keith. So,
I did practice it, but I have to tell you, my previous experiences are, even though I practice it, eventually I'll do something wrong.